Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled Nerve Transfers and AFM Part 2. My name is Rebecca Whitney, and I will be moderating this podcast along with Rachel Scott.
Hello, my name is Rachel Scott. I am a parent of a child with acute flaccid myelitis and also a founding member of the Acute Flaccid Myelitis Association.
The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. For today's podcast, we are pleased to be joined by Dr. Jonathan Cheng and Dr. Mitch Seruya. Dr. Cheng is Chief of Pediatric Hand, Peripheral Nerve, and Microvascular Surgery at Children's Medical Center in Dallas and Director of the Basic and Translational Research Nerve Lab at UT Southwestern Medical Center. He is an Associate Professor in the Department of Plastic Surgery and a member of the Joint Program in Biomedical Engineering. His research lab is developing treatments for long gap peripheral nerve injuries and strategies for neural interfacing in closed-loop man-machine systems.
Dr. Seruya completed his residency in plastic and reconstructive surgery at Georgetown University in Washington, D.C., where he developed a strong interest in helping children with congenital and acquired deformities. This passion for pediatric plastic surgery took Dr. Seruya to Australia, where he completed 2 fellowships at the Royal Children's Hospital, Melbourne. His first fellowship was in cleft and craniofacial surgery, and his second fellowship was in pediatric hand and microsurgery. Dr. Seruya now serves as the director of the Center for Brachial Plexus and Peripheral Nerve at Children's Hospital, Los Angeles. He delivers expertise in the field of peripheral nerve injuries, including brachial plexus palsy and facial palsy. He's also engaged in clinical outcomes-based research as a means of optimizing treatment modalities and functional outcomes.
Well, both physicians, and thank you for joining us today. We sincerely appreciate your time and you being on this call.
Wonderful. Thank you.
Thank you.
We'll just jump right into our questions. And I'd like to start for those who may be new to hearing about nerve transfers. Dr. Cheng, if you can start us off with a quick overview of what nerve transfers are and how they're used to help patients with AFM.
Sure. Nerve transfers are a reasonably new treatment option in peripheral nerve reconstruction. And by new, I mean more recently in the past 15 to 20 years. Before that, nerve grafts were really more of what were being done. Nerve transfers are essentially trying to rescue or restore the nerve supply to a muscle that's lost its controlling nerve supply by moving over an adjacent, a nearby or sometimes far away nerve that controls a different muscle that is still working, and taking that nerve and moving it over to the muscle that's lost its nerve supply in order to give it a new supply of control through the nerve that's moved over. And it's really, in some ways, quite as simple as that.
Thank you for that. Dr. Seruya, do you have anything that you'd like to add as part of an overview of nerve transfers?
Well, it's interesting. People will ask me, how new it is, and I would say it's become more popular in the last 15 to 20 years, but in actuality, it was first described in the 40s by a Russian surgeon, and we've come a long way from the 40s when nerves were placed on tension and the nerves connections were placed too tightly when they were doing that, and that led to a lot of failures. And so, like most of anything in medicine, initially we haven't fine-tuned the operation and it gets a bad reputation. But then as we figure out better ways to do the operation, it gains popularity, and then we find ways of applying it from the initial trauma to a birth-related palsy to now a acute flaccid or transverse myelitis situation where a nerve is turned off in the spinal cord and we're bypassing that with a working nerve from a different area that's more expendable. And so that's kind of the approach on that.
Thank you. Thank you both for that overview. Moving on to the next question. Are transfers only done for muscles with no activation, or is it possible to do a transfer if a muscle has some function? Dr. Seruya, would you like to start with that one?
Sure. I think, our approach to AFM and transverse myelitis has definitely evolved to initially I was more conservative, and you would either say do the nerve transfer or do not do it, in the sense of do you completely disconnect the natural nerve supply to that muscle, and do you place your nerve transfer to it. Now we can actually, in the situation of having a partially working muscle, think about doing what we call an end to side transfer, which is the idea of taking your donor nerve and not connecting it end to end to the target, but tapping into the side of it. And in that way, you're not disconnecting the natural nerve supply to that muscle. If it has something, you can actually boost what's there with some new electricity. The other situation is that we think of nerves as just having one area or region of nerve supply. If you think about the axillary nerve, which is a nerve that controls your deltoid, there are multiple branches within that. And so you don't necessarily have to go to the entire caliber of the nerve. You can actually select specific areas within it to boost up, whether end to end or end to side, and leave what's still working in that nerve be.
Thank you. That's very helpful. Question, and this one, Dr. Cheng, I'll ask you. I know Dr. Seruya noted this in his previous answer, but are nerve transfers
Mhm.
only for flaccid paralysis, or is it, how would it work and how is it used, like he said, for like boosting additional signal?
So are you saying specific to AFN patients or nerve transfers in general and all of how they're used?
I guess in how they are used, or if it is indeed different for acute flaccid myelitis patients, if it's only done in those um, flaccid muscles, or is it something that can also be used for patients with transverse myelitis who may have some spastic paralysis?
Uh-huh. Um, so there's a vast body of experience that we draw on in order to kind of put nerve transfers in their proper place. And as you know, these are surgical reconstruction techniques that have been used for a long time or for a number of years for patients who have brachial plexus injuries and also, nerve injuries or loss of nerve function, either as a result of trauma or even surgery for cancer or some such other procedure. And as time has gone on, it's been expanded to more and more different uses. Um, for instance, there are certain patients who have spinal cord injuries, and that way it's more similar to some of the kind of central spinal cord types of manifestations of transverse myelitis, where the problem is not that the nerve that supplies the muscle is not working, but the muscle is actually not being able to be controlled through the other pathways higher up in the spinal cord. And then the other situation is that nerve transfers have become increasingly applied for patients who have compression neuropathies where the nerves are still connected, but for some reason they're not working well. And those two things, I think, are what we draw on to guide us in the use of nerve transfers for AFM. And so it's three specific circumstances. One is where there's flaccid paralysis, where the nerve and the muscle are not working entirely. And in that case, I think that the answer is fairly clear and straightforward, where if there is a nearby nerve that's available, then there should be reconstruction done. The second thing that I was mentioning is in cases where it's actually some dysfunction as a result of the spinal cord injury. And the group that Dr. Moore works with at Washington University, namely Dr. McKinnon and Dr. Fox, they're have really developed the use of nerve transfers for spinal cord injury patients and giving them the ability to control their hands again. And so there are also some applications for the spinal cord related aspects. And then the third thing, as Dr. Seruya alluded to, is nerves that are still connected to some extent, but either incredibly weak or not able to be controlled in any kind of obvious way. And I think that that's really where the practice and the treatment of AFM is evolving in the use of nerve transfers. And the information that's being gained at this point ranges from when to do the surgery to what is the appropriate amount of weakness that is necessary in order to make the surgery worthwhile. And I think that all of those things are still a little bit in question at this point.
Thank you, Dr. Cheng. That's very helpful. Dr. Seruya, do you have anything you'd like to add to that?
I think Dr. Cheng did a nice job of summarizing it. I think we can, probably as we go, we'll have more questions that we can specifically answer.
Yes, absolutely. Another one from our community was asking if nerves from a donor can be utilized if the patient doesn't have enough live nerves of their own. Is that a possibility?
Is that
for you? Want to take that?
Yeah. Sure. Essentially, when we look at, for instance, an AFM or transverse myelitis, what we're looking at is the analogy is somebody goes into your house and shuts off the circuit breaker, and in this case, it's turning off the spinal cord, and now you're looking for a way to boost power. And so you can only boost power from another source that's working, live electricity, where you can take that electricity and tap into those wires that are currently off right now. When you consider taking donor nerves from somebody else, you're cutting them out of the body. They also don't have any electricity. So unfortunately, you have to use a working nerve, healthy, your own nerve with a electrical source. It's got to stay connected to the spinal cord, and all you're doing is disconnecting it from its original target and directing it to a new target. The equivalent would be somebody goes to your house, they shut off the circuit breaker on the first floor, second floor is working, let's steal the electricity from that closet and direct it to your downstairs fridge, which is more important. And so, unfortunately, you can't take from another source, being, let's say, somebody's, in this case, it would be somebody's other house where, you can't cut that electrical supply out and transplant it to your house because it's still off. So from our standpoint, as of yet, we just don't have the techniques of being able to take from another donor. It has to be the same person.
Thank you for that. That's very helpful. I appreciate your analogies. They definitely help put it into perspective. So thank you. Another question, Dr. Cheng will ask this of you. What risks do nerve transfer surgeries carry? Is there a chance of causing more damage during this type of procedure?
Yes, to some extent. I think that the surgeries themselves are quite safe regarding the nerve reconstruction aspects. The things that we worry about are patients who have some effect of their AFM on their ability to breathe, and the primary or the priority in that case is making sure that the health of the patient is preserved and that we don't compromise that in any way. And so really, if there's a breathing problem, that has to be the number one priority. Other than that, for the surgeries themselves, even though sometimes they can be lengthy, for the most part, they're quite safe. They're not super invasive, and there's usually not a whole lot of blood loss during these types of procedures. The risks regarding the nerve reconstruction are that one, that if there is a nerve that is currently working and we're looking to increase its function, we are always extremely careful to take care of it in a way that preserves that function and does not decrease the movement that the muscle already has. And so some of those techniques are similar to what Dr. Seruya was saying, so if I'm going to the deltoid muscle and it has 3 different branches that supply muscles, if one of those works and the other 2 do not, then I may leave the one that works and then amplify or increase the amount of potential usability of the 2 parts that are currently not working. And so we really have to kind of draw on the best of our abilities and our knowledge in order to really look into the specific components of the nerve like that. The other thing is that often whenever we do nerve transfers, logically, when we're borrowing from one nerve and moving it over to another one, it's to, what's stated as robbing Peter to pay Paul. And so basically we're taking from a nerve that is currently working that supplies some function and taking all or part of it for some other function that is more important than the part that's being taken from. And for instance, for a child that does not have the ability to activate their deltoid and move their arm away from their body, often those nerve transfers are taken from the nerve to the triceps. And the nerve to the triceps is, 3 different heads of the triceps, which is where the tri comes from, obviously. And so there are actually nerves to 3 different parts of the triceps. And some of the AFM patients that I've treated, 2 out of the 3 heads of the triceps are working. And so the challenge is to take from one of those 2 heads and move the nerve to the deltoid in the nerve transfer and then preserve the other head of the triceps that's still working. There have also been circumstances where only one of the heads of the triceps is working, and the other 2 are not, and that one head of the triceps has to be borrowed from in order to try to give the ability to support the shoulder, both in its stability and getting the arm away from the side. And so those are really things that we try to talk about and sort out ahead of time so that everybody has clear expectations about what's going on and what we're doing.
Thank you very much. A question that came in while you were answering this last is it possible to take a donor nerve from the opposite extremity, from the other side of the body? So
yeah, I think it depends on what is being referred to as a donor nerve. And so kind of in nerve transfer lingo, the donor nerve is the nerve that's currently functioning in the patient's own body that's being borrowed from. And in that case, the answer is yes. There's actually a nerve transfer that is well recognized in brachial plexus reconstruction, where one of the nerve roots from the brachial plexus, which is the C7 nerve root, it's called the cross C7 or contralateral C7 nerve transfer, can be borrowed from the other side and routed over to the more severely affected arm. I've done that procedure before. It has some issues, but it's really done for the situation where there's no available nerve transfer donor in the arm that's being treated. So that's nerve transfers. There's also the idea of a donor nerve being a nerve graft. And I know that Dr. Seruya was kind of talking about this. I just wanted to be clear. So nerve transfers and nerve grafts are different. Sometimes nerve grafts are necessary in order to make a nerve transfer work because the 2 ends of the 2 nerves, the one being borrowed from and the one being transferred to, are too far apart. And in that case, a nerve graft is essentially like a splice or a patch between the 2 ends of the 2 nerves that's taken from the patient's own body, usually from the leg, and that's the sural nerve. That's the one that's used most of the time. But there are also nerve grafts available in the arms, whether it's the arm that's being treated or the other arm. Both of those are possibilities. And then nerve grafts have been taken in the past from donors, meaning from other individuals, whether it's a organ donor or some other individual. And in those cases, nerve grafts from other donors are not used very commonly. except in special circumstances, and none so far in my practice.
Well, thank you so much for answering those questions regarding kind of the questions people ask when they're considering nerve transfers. We have a few questions about what it looks like after the nerve transfer. So Dr. Seruya, we'll start with you. What is the recovery time for surgery? I know it varies depending on what exactly is happening in the operating room, but what is the window we're looking at?
So as you mentioned, it basically comes down to what donor nerves we use, and I break it up into local versus breathing associated nerves. So are we using nerves within the arm as donor nerves, or are we using breathing nerves such as your intercostal rib nerves and your phrenic nerve, which is your diaphragm nerve? If it's local nerves in the arm, for my patients, they typically spend one night in the hospital. They're 3 weeks in a sling to protect the connection so that they do not pull away from each other. And then after that, we then begin the process of therapy. It's graduated, starting with active and passive range of motion, and then supplementing in sensory level e-stimulation, electrical stimulation. And then based on certain milestones, which are both time and muscle function related, we then escalate that process. When it comes to nerves that are used breathing wise, whether it's ribs or the phrenic, and that distance has to be traversed across your shoulder joint to the targets. And now we're more worried about disconnecting those connections because of tension, because of any movement of the shoulder. Those patients can be immobilized up to 8 weeks, whether it's in a sling alone or sometimes in a cast for the very young patients. When ribbed nerves are used, or the phrenic nerve to span across a joint, once the 8 weeks are up, then we start to get them moving. Again, we're most concerned about shoulder overhead reach because we worry about pulling away from the donor and the target nerves. And so we're just a little bit more cautious with that. Also, the time frame for recovery in terms of getting to see results varies. Local nerves typically turn on faster than using breathing nerves. The reason being, breathing nerves such as the rib nerves are mixed motor and sensory, so their electrical output is less, meaning less electricity for them to give to their targets. Also, there's a learning phase that's not as intuitive with the breathing nerves. And so there's a difference in terms of the expectations for when we can start to see recovery.
And that does lead us to our next question. How quickly should function be restored to areas, and what is the success rate in restoring full functionality? So Dr. Cheng, I don't know if you want to start by addressing that.
Sure. And so that Dr. Seruya touched on that a little bit, which is that the recovery of the patient overall is different from the recovery of the nerves. And so usually by about six weeks after surgery, the patient's basically doing everything that they were doing before they had the reconstruction. And then comes the waiting process for the nerves to actually grow, the axons to grow within the nerves after they're transferred, and then to get to the muscle and start working. And that takes generally somewhere in the 9 to 12 month range, with variability depending on the age and the size of the patient. So for really young children, like babies and toddlers, it's more in the 3 to 6 month range. And then for older kids, more like 9 to 12 months. Some specific reconstructions, like the ones that go to the other arm on the other side, may take longer, 12 to 18 months. And so typically about 9 to 12 months, we start to see whether the reconstruction worked or not. And I think that you can kind of gather from that statement that I make that, it's not a guarantee that full functionality will be restored. And at this point, we mainly have the data that we have from brachial plexus reconstructions to draw on in terms of the total numbers. I've actually, with my group, done some analysis of the patients that we've taken care of with these types of conditions over the last 10 years. And the outcomes and the results from the reconstruction, I think, are fairly comparable to what's done for brachial plexus injuries. And I think that the recovery is greater the closer you are to where the nerves live in the spinal cord. And so the higher, the better results are in the shoulder, and then and the bending the elbow, and as you move down further toward the hand, uh, then it becomes a little bit more variable, all things considered. Although for some nerve transfers that are done for finger movement and hand movement, the results are also quite good. It's really difficult to generalize and say that any one patient's going to have full function depending on what their uh, deficits are. And so the more things that there's a problem with, the less nerves there are to borrow from, and the more difficult it is to return full functionality.
Dr. Seruya, do you have anything to add about the results you've seen in restoring function?
Yeah, I think several points. One is the recovery itself was really dictated by how quickly do we get in there from the time of paralysis. So we're starting to look at my numbers, and on average, initially I was treating patients around 16 months after paralysis. Obviously, that was not my goal to do it at that point, but that's when they were coming to see me. Obviously, the longer and the further out you are from the paralysis, the longer that the muscles had time to atrophy, it's going to take a lot longer to get current back in there, to get the muscle to beef up and to see results. So one is time of surgery from the time of paralysis is one factor. Secondly is the strength of the donor. Obviously, if we're using local nerves such as wrist flexors to biceps or triceps to deltoid, we're going to get more function out of that patient than using mixed motor sensory nerves such as ribs, which have less electrical output, which are further away in their distance in terms of where we plug into. And so that second thing is the donor. Thirdly is, in my experience at least, and this kind of mirrors the experience of Shriners that they recently published, is that the best results we see are in the elbow and secondarily at the shoulder. From everything that I see, the shoulder, because it has so many more muscles, so many more areas that are affected, and because of the demand, these muscles are a lot bigger than, let's say, muscles within your hand or muscles within your elbow, that simply turning on the rotator cuff and the deltoid, at least in my practice, has not been enough to get full function back in the shoulder. I have had it in some patients, but generally speaking, the results in the shoulder are less stellar than they are at the level of the elbow. And maybe partly because on the average, I'm seeing patients almost 16 months out, which by all standards, most people say that nerve transfers aren't indicated beyond 18 months in general. That being said, we've had good results up to 24 months, and we're waiting to see about 36 months after paralysis. And from the standpoint of the hand, if there's a specific transfer done, I've done wrist extensor to finger flexors for the thumb and the index finger. I've gotten great results from that, but I've also gotten less than great results. So it really depends on when we're getting to them, the strength of the donor, but in general, the shoulder has been, for me, the least impressive of the outcomes.
Well, we're grateful for you guys taking time to talk about it today. I hope that you've seen people sooner with this group of 2018 kids than the group of 2016 kids. It's certainly talked about a lot more in our community of parents. So we're hoping that people are getting to everyone, getting to see surgeons quicker. Our next question is about the success and at what point you would consider a nerve transfer to be successful or unsuccessful. So we talked about, how long to see function. So is there a point where you'd say, no, it was not a success? Dr. Cheng?
Generally, I start to see recovery around 9 to 12 months if it's going to occur, and typically if I have not seen substantial recovery by the 12 to 18 month range, it's probably not going to be very successful.
Okay, thank you.
And so I think that in this case we have to be clear about what success means. And what I'm referring to as success is whether the transfer worked or not. Meaning that the nerve that was borrowed from grew into the muscle that it was being redirected to, and that muscle started to work. coordinated function, meaning, kind of the overall movement of the various parts of the extremity, I think, is a more difficult thing. And like what Dr. Seruya said, for shoulder movement, the great results that we see where the deltoid and the supraspinatus muscle are fully recovered still usually only provide about 60 degrees of mobility in terms of getting the arm away from the side, and that's still not anywhere close to the full 180 degrees or more that you're able to usually, get your hand fully above your head. And I think that speaks to the fact that there are many, many more muscles involved in the movement of the extremity than the limited few that we have the ability to intervene on. And so, for these reconstructions, the goal is to do as much as possible. But unfortunately, it still does not come close to providing full functional recovery.
Dr. Seruya, what long-term complications are associated with nerve transfer? For instance, we have some parents who report that their kids have neuropathic pain, which is surprising since we're talking about motor neurons. So the follow-up question is, why are some patients experiencing neuropathic pain after nerve transfer or decompression?
So that's interesting. In terms of complications, in general, you have the immediate complications in the operating room, and then you have the long-term ones. In the operating room, when breathing nerves are used, such as the ribs, we do worry about what we call a pleural tear, which is the tear in the lining of the lung, because the ribs are right adjacent to your lung. And then that may subsequently require a chest tube to decompress the area. So those are reported complications that can come up. Other complications immediately in the operating room would be taking too many breathing nerves and having the patient decompensate with the requirement for a breathing tube. Other general complications would be bleeding and infection. All these in general are quite low. In my practice, knock on wood, we haven't seen this, but there's always a possibility of that. In terms of neuropathic pain, how that would come up is this: whenever we're doing a nerve transfer, we're decompressing the donor nerve and its target out of the area of the soft tissue. And if you think about it, not just that, in certain nerves, like Dr. Cheng talked about the axillary nerve, if we decide to parse that out and only go to certain areas within that nerve, we have to split away the working areas from the area that's not working. And during that process of nerve decompression and neurolysis, that nerve is being peeled away from its blood supply, it's being peeled away from its adjacent areas, and it'll shut off for a bit. And that's a natural phenomenon, what we call neuropraxia. And when the nerve shuts off, it then goes quiet for 3 to 6 weeks, and then it turns back on. And when it turns back on, and as that electricity gets going, you may have the feeling of burning or tingling, and that can then generate neuropathic pain. And so it may be that, and I have not seen this in my patients in the long term, I've not seen patients beyond 3 to 6 weeks having this problem, but if there are patients out there, it may be just in the setting of the decompression, the neurolysis, the manipulation of the nerve, the motor nerve, that we're seeing that. And finally, each one of these motor nerves does have a small associated sensory nerve with them. It may be that in the process of cutting the nerve supply and turning back on the motor, when that sensory nerve is cut in the process, such as the axillary nerve, which has a sensory nerve to your arm, that that becomes then a neuropathic source of pain.
Okay, that's helpful. And can you elaborate a little bit on the difference between nerve decompression and neurolysis?
From my standpoint, they're one and the same, in the sense of a neurolysis is a more formal way of describing a layman's term nerve decompression, such as neurography is a fancy way of saying nerve connection. So I think they're the same. Parents will ask me, hey, can we just do a neurolysis or a nerve decompression? And at the end of the day, anytime we're doing a nerve transfer, we're decompressing the donor nerve and its target. And so part and parcel of any nerve transfer operation is a nerve decompression. By itself, a nerve decompression alone would not solve the problem. Again, if we look at the analogy of the house where the circuit breaker is shut off, and you may have a little bit of corrosion on the wires. Taking the corrosion off the wire doesn't solve the problem of there being no electricity at the power source. And so by itself, decompression neurolysis is not going to do it. But in conjunction with the nerve transfer, that's when you see the best outcome.
And using your analogy of the house, if we have, if the power source is just low and the wire's corroded, if you remove the corrosion, I think it sounds like nerve decompression, the hope is that removing that corrosion when there's a small signal coming through will help the signal be increased.
It should definitely help the signal being increased. Anecdotally, at least for the patients that I've seen, the few times where I've given the benefit of the doubt of the natural course of recovery being enough with just decompression, it hasn't panned out. If I could nerve transfer in general, I would, whether that's an end-to-side or an end-to-end. I haven't found that just strictly decompressing and leaving it with time, at least in my experience, it has not been enough to get a nerve and its muscle target to turn the corner. The only situations where I've done that is where I don't have a donor, when we thought maybe there was a donor, we just didn't have it. Or if, it was a mixed picture, I decided to give it the benefit of the doubt. And it's happened once where I've gone back in and said, you know what, it didn't turn around on its own. And I've gone back and then done the nerve transfer.
I have a
Dr.
request.
Cheng, yeah, go ahead.
I don't know what you were just about to ask of me, so maybe we're
I
thinking
was
the
going to
same
ask
thing.
what your opinion was on the role neurolysis and nerve decompression play. So you can answer that, or you can ask your own question.
Yeah, I will answer that, but I wanted to make a request for some more information first. Honestly, I cannot think of a single one of the patients that I've treated in the last 10 years who had pain that I attributed to being neuropathic pain, either from the injuries to the peripheral nerves from the AFM or from my surgery in particular. And I was wondering if you might provide some perspective as to what specific types of neuropathic pain you're referring to.
Okay, I'm gonna have to remember. Let me scroll back through our Facebook group. Had several different questions about this, so I can scroll back and look for it. While I ask the next question, if you want to talk about neurolysis and nerve decompression, I'll look that up.
Sure. Because I've certainly seen patients who, all of the patients that I see are usually co-managed by a neurologist and also a rehab doctor. And so for the most part, the overall general rehabilitation of the patient is not managed by me. But I certainly am aware of patients who have had things like, chronic joint dislocation or subluxation and things like that result in pain until that particular deformity or problem is corrected or addressed. But I don't think I've seen patients who have had pain from the nerves themselves. As far as decompression goes, Dr. Seruya is correct that whenever we go in and we free up the nerves during surgery, that's essentially what we call a neurolysis. In the peripheral nerve parlance, though, nerve decompression specifically is referring to anatomical sites of compression, as you may know, things like carpal tunnel syndrome or cubital tunnel syndrome, or compression of the peroneal nerve at the side of the knee, or the sciatic nerve in the buttock at the piriformis muscle. And that was a concern of mine very early on, because what we know about those particular sites of compression is that there can be certain folks who are predisposed to them because of their anatomy in those particular areas. But sometimes it can take an injury or an illness to manifest those compressions. And one of the known ways to reveal a site where somebody is susceptible to an anatomical site of nerve compression is to have an injured nerve. And so, as you know, the nerve overall is not healthy in AFM. And so early on, I had patients, for instance, who had foot drop deformity where I suspected that they may have had a compression of the peroneal nerve at the side of the knee. And similar to Dr. Seruya's experience, whenever I've done releases on those areas, it has not really seemed to play a role in their overall recovery that I could attribute to my intervention, as opposed to just their general overall recovery and the health of that nerve. And the other thing is that quite commonly, sites of nerve compression are manifested by changes in sensation, and it does not seem to happen very often in AFM patients where they have some sensory changes. The only times that I've seen sensory changes have been usually temporarily after I've done a nerve transfer where I'm borrowing from a nerve that also contains some sensation in it. But usually that corrects spontaneously over a few months. And so again, even though they have some sensory changes, that's usually numbness and tingling and not pain, or always numbness and tingling and not pain whenever it does occur, which is infrequent.
So I found a Facebook post about the nerve pain, and it sounds similar to what Dr. Seruya and you were talking about, where 2 weeks out from surgery, there was a hand that was tingly and sensitive. So that sounds like it may be consistent with what you guys are talking about.
Yeah. But it's just nerve pain is not something that I find happens very commonly after nerve transfer surgery, usually in the patients that I've seen.
Next question is regarding therapy. So Dr. Seruya mentioned his protocol about e-stim and therapy afterwards, but Dr. Cheng, do you want to elaborate on the value of therapy after a nerve transfer?
Sure. Usually, I view the surgical reconstruction as just part of a long continuum in the care of these patients. And there is therapy that's already ongoing up until the point that I see them and evaluate them, and potentially whenever I do their reconstruction. And usually immediately after my reconstruction for 6 weeks, I had the patient take a break from therapy and just kind of sit around at home and be a couch potato for the most part, just to protect the surgical site. And then after that, I request that they go back to doing all the different therapeutic modalities that they were doing before their surgery. And typically I don't have any specific therapy that I do for the reconstructed limb until the nerve transfer starts to work. And again, usually that's around at the 9 to 12 month point. The only time that I do more is if there's stiffness that results either as a result of the surgery or as a result of the nerves not working like they were not working before the surgery. And so that stiffness can be helped by therapy, but typically I don't do a huge amount of therapy for the reconstructed limb until after the nerve transfer starts to work, and then it's specific retraining.
Dr. Seruya, is there anything you'd like to elaborate on with that?
Yeah, I mean, we did touch upon the protocol that we've come up with for patients specifically with AFM. From my standpoint, the timing of seeing results varies from the time of, how quickly did we get in there? And so for me, if we get in a timely fashion in the first 3 to 6 to 9 months after paralysis, things could very well start turning on between 3 and 6 months. And so from our standpoint, at least once the immobilization process is done, which again, local nerves 3 weeks, rib nerves 8 weeks. Once that process of immobilization has completed its course, then we get them going. Because unless we get to an operation late, we do expect to see some degree of nerve turning on, muscle turning on in suit between 3 and 6 months for the elbow. The shoulder could take longer. But that said, that process does get delayed in those patients where I've gotten to them quite later. In general, for the patients that have gone later, the time frame of how long you were paralyzed does dictate about how long it'll take for me to start to see something. And so based on that, we still recommend the early therapy just to keep things moving, to prevent stiffness. and to get buy-in from the patient so that it's not this foreign process by the time that things are really turning on.
Thank you both for all of that information. Obviously, these surgeries are very intricate and very involved, and there are many considerations when talking about nerve transfers, including financial. We do have some questions from our families and community about different financial considerations. Have either of you run into issues getting insurance to cover these types of procedures? And if so, do you have any tips that you would want to share with parents when they're advocating for their kids to receive a nerve transfer? Dr. Seruya, do you want to start off on that one?
Yeah, thank you. For me, it's been a personal quest because I can tell you that in California 5 years ago or 4 years ago, nerve transfers were not covered in general, whether it was for trauma, for obstetrical, or for AFM. And so we had to, through the Children's Foundation, basically represent our case and explain what was being done, because any nerve transfer beyond one was considered experimental and considered not useful. And we eventually changed the California CMS law, Medicare state law, that these transfers will be covered from that standpoint. And we specifically used AFM, that population, as reason for that. Following that, though, recently I have run into issues across state lines where Aetna, in particular, has denied it, saying this is experimental surgery. And how we've gotten around that is twofold. One, it's very nice that Shriners recently published their paper of 16 patients, because before that I used to reference Dr. Chuang's paper from Taiwan in 2007, which was a population for nerve transfer alone of 3 patients, and they still looked at that as experimental. Now with having Dr. Zlotlow's experience of 16, it does add more data so that this is less of a experimental type of procedure, which it really is not, but to the insurance provider, they think that way. And so that has helped to provide more documentation, more specific peer-reviewed literature. And the second thing that's been even more helpful are the parents. And so I've been there last week, 2 parents in particular, where both cases were denied, and we explained that to both parents, and both parents advocated for their kid and spoke to the plan and spoke to them in detail, and were able to overturn the decision. And so as we've seen, and I've seen since, being a part of the AFM community since 2014, that the parents really have a voice, and this voice has really grown. And it's amazing to see, not just with advocacy, but from the standpoint of governmental advocacy, but even from an insurance standpoint, seeing the parents playing a huge role in advocating for their child, and it really does make a difference.
Thank you. Thank you for that. You actually touched on one of our other questions about this nerve transfer technique not being documented in scientific papers for AFM specifically, and thus insurers tend to not support it. Do you know when we can expect, or have an idea as to when we can see additional scientific papers come out to help support that?
If that's for me, yeah. So we do have the 2007 Taiwan experience of just 3 patients, the 2019 Shriners experience of 16, and then we're collating my data now. I've at this point now operated on 30 patients with AFM, and I'm just waiting for 10 of those to have more long-term data. But at least on the 20, we'll publish that data. We're just collating it now and getting ready to submit. Tying into that, we've now, right now, under peer review, have a paper discussing the natural history of patients who don't get nerve transfer surgery. Like I said, a lot of patients came to me late, and so we have their data on what were their strength scores at the time of illness to the time of 9, 12, 16 months later. Where are they? And what we found, and again, we're hoping to get this accepted, is that by 3 months, you can tell which patients are going to recover enough on their own and which are not. And at least in the acute flaccid population patient, we're able to demonstrate that these 2 populations of patients really separate from each other by 3 months, and not necessarily two different patients. Could be the same patient, two different limbs, one limb more affected than the other, and by 3 months you can tell one limb's bouncing back and one arm is not. And so that for us has given us the data to understand that simply leaving it for time and therapy alone in about 57% of patients is not going to be enough, meaning 43% of patients will on their own get there, and the other 57% won't. And so that for us has given an argument to the insurance company to say, listen, doing no surgery is going to mean patients with long-term impairment. And surgery is not going to reverse that per se, but it will improve upon the function and hopefully alleviate that impairment. And so while we have the first paper under review right now, which is demonstrating what happens if nothing's done and to sort of bolster doing surgery, we're now getting ready to prepare the second paper, which will be, this is what we can expect in terms of outcomes.
Thank you so much for that information. It's very helpful on the advocacy side of this with the insurance companies. Dr. Cheng, question for you. I know you probably
Hmm.
see families from all over the country as well.
Sure.
So many are
Yeah.
traveling for these surgeries. Can you offer a
Right.
compelling reason to go to bat with insurance companies to cover these surgeries at a remote facility
Yeah.
versus seeing one that's possibly qualified near
Sure.
the family?
It's interesting to hear about the insurance denials because I cannot account for the systems issues behind that. I honestly have not ever had a single patient in 10 years denied for reconstructive surgery for this condition. And so it actually comes as a great surprise to me. I've heard Mitch talk about it before. But I still not sure that I understand, and I consider that to be incredibly unfortunate. The issue of traveling. So the other is that it the flip side of that is I'm not surprised to hear that that's how some of the insurance companies view it. And the reason that I say that is because I can actually distinctly remember presenting outcomes from patient where I did lower extremity nerve transfers to a very specialized group of pediatric hand and nerve surgeons, maybe 7 or 8 years ago, and actually hearing from that group as well. Oh yeah, we consider, at that time it had not been stratified from TM to AFM, that we consider TM to be, a spinal cord problem and not a peripheral nerve problem. And so make sure that you're not taking away things that are going to recover on their own anyway. And so that's actually something I've heard from surgeons. And that I think is very closely related to why I feel like it's the most compelling to have patients travel to receive care from me. There was a period of time in the middle, maybe 4 or 5 years ago, where there were a number of patients that were referred to me from outside. And when I saw them, I felt like they needed surgery. But I knew of pediatric brachial plexus surgeons closer to them, nearby home. And I recommended that they go to those surgeons so that they would not have the inconvenience and the expense and the travel and all those things related to, and access related to coming to me. Sometimes, it's a 3 or 4 hour flight even. And that didn't work out so well. And what I found was that I could not really realistically, fairly expect a different surgeon to see the indications, the reasons to have surgery as the same as what I saw them to be. And there are a few of those kids that I felt needed surgery that I referred to other surgeons, had those other surgeons tell them, no, you don't need surgery. And it's hard for me to really know, which was the right answer or the better answer. But since that time, I've stopped doing that. And so now whenever I see patients in my own center, I treat them accordingly. I think it's good to have a surgeon who has experience with diagnosing and decision making on AFM in particular, because even though the surgeries are very similar to what's done for other pediatric brachial plexus and peripheral nerve injuries, the decision making and the knowledge base, I think, is very different.
Thank you so much, Dr. Cheng. We're actually coming to the end of our podcast, but I think we have maybe a couple more minutes for one additional question. The information you both have already offered here is incredible and invaluable to our community. So thank you so much. But if we can ask one more question, we truly appreciate it. Rachel, do you want to go ahead with that?
Yes, we talked about in the previous podcast a little bit about what's being done for the phrenic nerve with Dr. Z, but Dr. Seruya, I know you're also doing some things with the phrenic nerve to help restore some respiratory abilities. I'm not sure if Dr. Cheng is as well, but Dr. Seruya, we wanted you to fill us in on what's being done in your practice with the phrenic nerve.
So from the standpoint of the phrenic nerve, in our brachial plexus center, we have a pulmonologist named Dr. Keynes who evaluates everyone with pulmonary function tests, diaphragm X-ray, nerve conduction study of the phrenic nerve. And that in conjunction with Dr. Shin, who's a pediatric surgeon who does video-assisted approaches to the phrenic nerve. Every patient's different. We work patients up to determine what's the status of the phrenic nerve. If both nerves are not working, there's an indication to try to nerve transfer to one of them. If one of them is partially working and the other one is not, then the recommendation would be to apply a pacer to the one that's working quite well. You have to have some degree of electricity in the phrenic nerve to pace it. You can't pace it with no electricity in it. But in the situation where it's bilateral and where a patient does have donor nerves, we are offering nerve transfer as an option. Patients have not yet met the criteria in the sense of checking all those boxes, bilateral injury with a suitable donor, to say that we have the experience yet for that. But that is the approach that we're applying. And there will be those patients that will come up, and at the time, if there is a suitable donor and both sides are affected, then the goal is to nerve transfer to at least one of the targets and to apply the pacer at the same time. In that way, the pacer can augment whatever electricity will naturally now start going through that phrenic nerve.
And are you doing some version of a nerve decompression as well with the phrenic nerve?
So like anything else, when we're looking to target the phrenic nerve, it's decompressed out of its space during that nerve transfer operation. It's decompressed out of the anterior scalene muscle. That by itself will not solve it. It needs current. And so the question becomes, what are the suitable donors? Every patient is different. We go through our decision tree as to whether or not the donors include the intercostal rib nerves. Does it include the accessory nerve or something different? And so, from our standpoint, we're comfortable approaching it that way. It's really just a matter of, does the patient satisfy the safety concerns that may come up, and do they satisfy, as importantly, the functionality? Are there donors that can even be transferred? And we have a great team around it in the sense of we have very thoughtful pulmonologists and neurologists that are looking at these patients with every form of test to ensure it's safe.
Thank you so much. Dr. Cheng, do you also do work with the phrenic nerve in your clinic?
I have not had any patients that needed it, fortunately. But as Dr. Seruya said, this is something that's been looked at in spinal cord injury patients for a number of years, and it's exactly like he says. The phrenic nerve comes from C3, C4, and C5 in the spinal cord, and the most common nerve that's transferred to that is the spinal accessory, which is one of the cranial nerves. But as we all know, in AFM, the spinal accessory is actually affected also because of some of the changes in the brain stem. And so really the goal is to get any working motor nerve that's close enough to the phrenic nerve, and preferably as close as possible to the diaphragm, to provide a nerve supply to the diaphragm in order to be able to pace it. And really, it's the biology of it being that the phrenic nerve needs to have some working nerve fibers in it in order for the pacer to work. And we still are relying on the pacer to do the job of breathing.
Thank you so much. That actually brings us to the very end of our time on the podcast. I know we have so many questions and I wish we could get through all of them. But again, I truly can't thank the both of you enough for taking the time out of your day to join us on this call. So thank you once again. And also for any families who have inquired or would like the contact information for either Dr. Seruya or Dr. Cheng's clinic so that you may set up appointments, consultations, please feel free to email us at info@myelitis.org and we can share their clinic contact details with you. Once again, thank you, Dr. Seruya and Dr. Cheng, and also Rachel for being a part of our podcast today. I hope you all have a good day.
Thank you.
Thank you. Thanks for all that you all do.
Thank you. Bye-bye.